I'll continue in the obstetrics section discussing fetal growth abnormalities. Some general definitions: low birth weight is less than 2,500 grams. Intrauterine growth restriction is less than the 10th percentile. Macrosomia is greater than 4,000 to 4,500 grams, whereas large for gestational age is greater than the 90th percentile. We'll discuss all of these here. Fetuses with intrauterine growth restriction weigh in the bottom 10th percentile for gestational age. Now, there's a physiologic connection when talking about IUGR. Early in pregnancy, growth occurs via hyperplasia and hypertrophy, whereas later in pregnancy, growth will depend increasingly upon hypertrophy rather than hyperplasia. This leads to the two different types of IUGR. Symmetric IUGR is where the brain is in proportion to the rest of the body, and typically occurs at less than 20 weeks gestation. These are more commonly associated with heritable factors, such as chromosomal abnormalities, immunologic abnormalities, chronic maternal disease, fetal infection, and multiple gestations. This is opposed to asymmetric IUGR, where the brain weight is not decreased, and the abdomen is smaller than the head. This will typically occur at greater than 20 weeks and is related in some way to uteroplacental insufficiency. On the Step 2 exam, you may be asked to diagnose IUGR and identify the risk factor which may have led to it, and it's important to understand the different etiologies. As we discussed, chromosomal abnormalities can cause IUGR, along with neural tube defects. Infections are an important cause, particularly early on in pregnancy. Viral causes include rubella, varicella, and cytomegalovirus, and protozoans can also cause IUGR. Multiple gestation twins or triplets will typically be smaller than their matched singleton controls. Different maternal diseases, some of which we've discussed, can also cause IUGR. Hypertension and renal disease are a common cause. Maternal malnutrition, as well as substance abuse. In fact, smoking is the #1 preventable cause of IUGR in the United States. Women who smoke deliver babies who are on average 20 grams smaller than their matched controls who do not smoke. Finally, different types of hemoglobinopathies can also be the cause of IUGR. There are a couple key points about the diagnosis of IUGR, starting with the physical examination. In general, the fundal height between 20 and 36 weeks should equal the gestational age in weeks. So for example, a patient's fundal height at 28 weeks gestation should be 28 centimeters above the pubic symphysis. Between 20 and 36 weeks, the fundal height should increase on average about a centimeter a week. A discrepancy of greater than 3 centimeters should prompt an ultrasound exam. Diagnosis is ultimately made when this ultrasound is performed and biometry is performed in order to obtain an estimated fetal weight. The next few slides review the key ultrasound images obtained during fetal biometry. These measurements are taken together in order to come up with the estimated fetal weight. Seen here is the occipital frontal diameter, followed by the biparietal diameter and the head circumference, which are all important biometric measurements of the fetal head. Next, measurements in the abdomen are obtained, and we obtain measurements from side to side and front to back. You can also come up with an abdominal circumference from these measurements. The final measurement is a femur length, which is shown here. If your fetal biometry results in a diagnosis of IUGR, serial measurements should be obtained every 3 to 4 weeks in order to evaluate for fetal growth. In general, IUGR babies are at greater risk for morbidity and mortality. Complications include increased rates of preterm labor, stillbirth, fetal hypoxia, overall lower IQ, seizures, and mental retardation. There is no conclusive treatment for IUGR other than trying to prevent it. Common prevention techniques involve advising patients who smoke to quit smoking, and to prevent maternal infections by obtaining routine immunizations. Ultimately, the obstetrician needs to determine the optimal delivery time, weighing the risks of fetal death with the risks of neonatal death. This can be done by using serial ultrasound examinations for growth, as well as other antenatal testing for fetal well-being. I'll turn now to macrosomia, which is the estimated birth weight over 4,500 grams. Another term is large for gestational age, which is a birth weight greater than the 90th percentile. Risk factors include maternal diabetes and obesity, which we've discussed previously, advanced maternal age, post-term pregnancy or pregnancy beyond 42 weeks gestation, and fetal genetic disorders. One of the commonly tested fetal genetic disorders is Beckwith-Wiedemann syndrome, which is a pediatric overgrowth disorder involving a predisposition to tumor development. It usually occurs sporadically, but familial transition can occur in about 15% of cases. The hallmark features are omphalocele, macroglossia, and macrosomia. However, the clinical presentations can vary pretty widely. The diagnosis of macrosomia by physical exam is the same, only opposite as that of IUGR. Again, reminding ourselves fundal height between 20 and 36 weeks should equal gestational age in weeks. Macrosomia should be expected if fundal height is greater than 3 centimeters above gestational age. If you have a physical exam that is suggestive of macrosomia, we have to obtain an ultrasound. And again, ultrasound confirms estimated weight by femur length, abdominal circumference, head circumference, and biparietal diameter. The head measurements are shown here, the occipital frontal diameter and the biparietal diameter indicated by the calipers. Measurements again of the fetal abdomen in order to obtain the circumference. And finally, the femur length. Complications which occur in macrosomia include shoulder dystocia, birth injuries such as a clavicular fracture or a brachial plexus injury, low APGAR scores, and hypoglycemia. Here we see a chest x-ray, which is an example of a clavicular fracture, which should lead us to be concerned about brachial plexus injuries. Reviewing the brachial plexus injuries, the common ones are the C5 to C6, resulting in Erb's palsy, which is weakness of the deltoid and infraspinatus and biceps muscle, resulting in an upper arm that's adducted and internally rotated. If the injury occurs at C5 through C7 or Erb's palsy plus, you can have extension and pronation of the forearm and flexion of the wrist and fingers, referred to as waiter's tip. Klumpke's palsy at C8 to T1 is the most infrequently observed pattern and manifests as isolated hand paralysis and Horner syndrome. Treatment of fetuses with macrosomia involves a careful delivery plan. An induction of labor can be undertaken if the lungs are mature and the estimated fetal weight is less than 4,500 grams. A cesarean delivery can be offered if the estimated fetal weight is greater than 5,000 grams. The American College of Obstetricians and Gynecologists recommends delivery by cesarean section for women who have estimated fetal weights greater than 5,000 grams in women without diabetes and greater than 4,500 grams in women with diabetes.